presentation could be all the way from a fairly youth athlete or a mature professional athlete all the way through to elderly people who are trying to keep fit, trying to fight the good fight. And the key to the answer to that question is the diagnosis. Without the right diagnosis, there is no right treatment. And so after taking a history, the key would be to decide what the best treatment would be. The two probably commonest pathological scenarios, let's exclude a catastrophic Achilles tear. The two commonest scenarios, in the younger athlete, there is often an intratendinous tear, and that would typically be precluded by a normal healthy tendon, normal activity, normal sport, and then a sudden onset localized pain in the tendon. And that would show up on an ultrasound scan and on a clinical examination. The treatment for that varies from simple rest and a boot all the way through to using a platelet-rich plasma injection, which has some good evidence that that can accelerate healing and perhaps even improve the quality of the healing, all the more important. On the other hand, the more mature athlete or a recreational athlete, a hill walker, a jogger, they often have stored up some problems over a period of time, and they attend with a thickened, chronic, painful tendon, which has had micro injuries over the months or years, finally till the individual can't cope anymore, and then they attend with pain. They often do very well with a high volume injection. When you get these injuries, the healing process gets a bit confused, to paraphrase, and you get an ingrowth of new blood vessels, and they bring with them some pain receptors, microscopic nerve endings. And to try and separate those out from the tendon appears to help the patients to recover and to reduce their pain. And all the more important, everything that we do on the physician's side of sports medicine is only as good as what the physiotherapists can also achieve as well. So that partnership between the doctor and the physiotherapist or the tissue therapist to make sure that the initial treatment and diagnosis is followed through is key. Because one of the biggest dangers in these situations is impatience, and patients can undo a lot of hard work if they get impatient and they do the wrong things and they return too quickly to running. So that's the long answer to a short question. There are other pathologies in the middle, catastrophic Achilles tears, which usually attend hospital, and there'll be other issues as well, but those are the two commonest that we can treat very effectively, but they do take quite a long time to recover, several months usually. So Achilles tendonitis is actually a misnomer. It's not an inflammatory process normally, it's more of a degenerative, painful tendon, which over a period has tried to recover itself invariably while the individual is continuing to exercise. So you get this chronic cycle of healing and then injury and healing and injury, and that leaves a thickened tendon which is painful, or with neovascularization, new blood vessels, and then usually an escalating level of pain prior to the patient attending. So it's not an inflammatory condition normally, although there might be a few rheumatological conditions that could present that way. It's usually overuse, small tears, and a determined patient who wants to keep fit and keep running and then needs help. Achilles tendonitis in itself is not a serious condition, thinking about, threats to your health. The seriousness is if it goes unchecked, it will only tend to escalate. The risks of rupture in an Achilles tendonitis / Achilles tendinosis appears to be relatively low. So that's good news. But unless you deal with it and you have the correct diagnosis and treatment, people who enjoy exercise and enjoy sport will find it's harder and harder, and that their performance will fall away, and that they will not enjoy the activity until it's sorted, which is probably for most patients is the key. They're related in the sense that the anatomists will connect the structures through a fascia. They are not related in the sense that they are two separate conditions. And again, plantar fasciitis is sometimes mistaken for small acute tears in the plantar fascia, or a plantar fibroma, which is a small degenerative area, very focused in the plantar fascia, midway through the substance towards the toes. And the treatment of each of them is quite different. And again, it comes back to imaging. It can be a really useful tool, and without that, it's very hard to get the diagnosis. But both are amenable to treatment and again, require some patience in their full recovery. No. The success of surgery is not is invariably not justifying the decision to operate unless there is a large tear or the patient has failed all of the conservative approaches and treatments. In the past, if we scroll back 20 or 30 years, talking to my surgical colleagues, surgery was a bit more common. And there are indeed areas where a degenerative tendon with a localized core of degenerative tissue can do quite well when it is carefully debrided. And so surgery still has a place, but it should not be first line. And there are plenty of treatments, the most important of which is good rehabilitation and good modification of exercises, which can lead the vast majority of patients to a good functional recovery without the need for surgery. That's a very individual situation, and made even more acutely relevant because of COVID, because accessing doctors around the globe has been creating challenges for patients in different societies, not least which in the UK here, where the NHS has been under pressure, and getting appointments and diagnosis has not been easy. And so that will affect patients' decision-making. And we've seen certainly more patients who have decided to come earlier, probably, who have been frustrated by the access to proper healthcare and by the telephone type treatment, which can only go so far without an examination and probably imaging. So my advice would be to come early, and likening Achilles tendinosis and Achilles problems, much with other injuries, as a blind alley. The longer you keep walking down that blind alley with no end, then the longer the walk will be back up to the open road. That's the way I would try and describe it to patients. The decision of when to come will be dependent on perhaps their job, perhaps on their pain thresholds, and perhaps their pre-existing fitness and their own stubbornness, which is not always a bad thing in exercise to keep going, or perhaps access to other exercise modules like swimming. So the smart patients who've had a problem before may resort to going back to swimming and cycling. Patients who've had Achilles tendinosis for the first time will probably come a bit sooner, and they may not have that repertoire of exercise and may rely on running. So there'll be a broad brush of activities, but the bottom line is the longer you go on with this condition, the longer will be the recovery and the harder to treat.